Hi, welcome to Do This, Not That. I'm Sue Self, licensed clinical social worker and behavioral health liaison manager for BJC Behavioral Health. Today, we're trying to understand and feel confident and competent when providing care for young patients who exhibit anger or aggression. Aggressive behaviors bring the potential for harm. Concern about this is legitimate. It's perfectly okay to be on guard and careful when someone poses a risk. The key is to push through our apprehension to manage the situation as well as to provide good care. This kind of behavior in children is sometimes surprising, and many times the intensity and the child's capacity for strength is alarming. In this module, we want to look at two elements of managing these behaviors. First is understanding the underlying reasons why the child may be behaving this way. Second, recognizing the warning signs is an extremely helpful tool in managing the behavior in the moment and preventing it in the future. In kids, behavior is driven by emotion, not logic. While some misbehavior may be due to negative attention seeking, anxiety, or defiance, full-blown outbursts of aggression are not usually due to personality clashes or a result of boredom. Why? Because aggression is a response to pain. It's like a blinking light on the dashboard of your car that tells you something is wrong under the hood. Anger is a secondary emotion. At any age, aggression can be exhibited as hitting, biting, kicking, and yelling or threatening. Tantrums with aggressive behaviors in 2 to 4-year-olds are normal, especially for children who are unable to express their frustration. Episodes of anger and even peer fighting among older children, say from 5 to 12, are normal, but frequent aggression or aggression directed at adults is not typical. Angry behaviors and attitudes are common in teenagers, but aggression is not typical. Aggression can be a symptom of many underlying problems. It's common in many psychiatric conditions, medical problems, and life circumstances. Psychiatric, acute chronic mental health disorders such as bipolar disorder, depression, or PTSD, schizophrenia, paranoia, or behavior disorders such as ADHD or oppositional defiant disorder. Developmental delay, traumatic brain injury, medications, physical pain, use or abuse of addictive substances, stressors at home or at school, or the experience of being hospitalized, trauma, including abuse or bullying, modeling after an angry parent, sibling, or peers. And finally, aggression can be a response to emotional pain, and often it's anger. Anger is secondary to other negative emotions. For instance, a patient can be afraid of things in the hospital and be angry because he's afraid. Emotions that can be provoked by hospitalization are fear and anxiety, afraid that he or she is dying and no one will say, anticipating painful or frightening procedures. Frustration, no one understands them or their experience, recovery that is slow or limited. Guilt, believing she caused her own illness, or the worry in the parent's face. Illness may be perceived as punishment. Embarrassment, physical and/or emotional vulnerability, loss of control over their bodies, demeaning procedures. Hurt, parents or others don't visit, missing out on life while they're hospitalized. Shame, like after a suicide attempt or injury from risk-taking behavior, feeling blamed for their medical issues. When encountering an aggressive or angry patient, first, know that it's not personal. As long as care is taken to not aggravate their emotions, know that you may not be the source of the anger. You're seeing the patient's reaction to other emotions she is experiencing. When working with any angry or agitated patient, there are 4 main objectives. Ensure the safety of the patient, staff, and others in the area. Help the patient manage the anger and maintain or regain control of her behavior. Avoid the use of restraint when at all possible. Avoid coercive interventions that escalate agitation. Think of two different scenarios. In the first, the patient is willing and able to engage with you. In the second, the patient is out of control, not impacted by or responding to your voice, or has a history of sudden outbursts of aggressive behavior. If the patient is angry but willing and able to engage with you, here are some things that you can do. First, take steps to protect yourself from any potential violence. Adopt a supportive stance, setting your body at an angle to the patient and keeping a distance of one leg length away. Speak calmly and simply in a reassuring but firm manner with a lower pitch, volume, and rate. Respond selectively. Answer all informational questions, no matter how rudely they're asked. Be as empathetic and understanding as possible. Ask open-ended questions such as, "Help me understand what's upsetting you." Use the philosophy of yes when possible. Be aware of body language and facial expressions that could exacerbate the outburst. If a patient exhibits aggressive behavior and you believe there's a potential for violence, follow these rules. Don't do it alone. Get other staff to help you. Approach from the front and maintain a safe distance. Be closest to the door and don't turn your back. Take all threats seriously. Consult and communicate with supervisors, coworkers, and shift to shift. Follow your organization's policy with regard to getting assistance. Don't avoid or ignore the patient's anger or aggression warning signs. Don't try to talk her out of being angry. Don't challenge the patient or participate by calling names or getting physical. Don't raise your voice, argue, or answer in any way that is confrontational. "What did I just say?" Demeaning. "Calm down, this is not a big deal." Insulting or abusive. "You're being a baby." Never touch, grab, hold, or even gently restrain an angry or aggressive patient. Don't get close enough for an aggressive patient to grab or hit you if you can. Model anger management, such as, "I start to feel upset when you behave this way, so I'm going to go and take a minute to calm down." Give the patient words to express herself, such as, "I know you're scared," or sad or frustrated. Identify with their pain. "I remember when I was in the hospital, I was really worried." Set positive limits. Instead of saying, "Don't you throw that doll," say, "After you put the doll on the table, I can bring you a snack." Avoid power struggles with the child. They're always lose-lose situations. Provide a cooling off period to allow de-escalation without losing face. Eliminate triggers. Get the patient away from what is triggering her anger. Remove an antagonist or distract her from her cell phone or Facebook.
Hey, they'll be up here in the next hour or so to take her to psych.
Okay. Who said so? No one told me! No way! Hey, it's not okay to do that. You're upset, right? Psych floor? There is no way! Don't you get that? I can see that it's really a shock, and it's okay to be upset, but you cannot be hitting and kicking me. I don't care what you think. This is crap. I'm not going. Who told you I was going to psych? Well, I got big news of my own. No one is making me go to the nut floor.
I'm sorry you didn't know. I don't blame you for being upset, but you can't hurt people.
Right about now, you're going to decide if the patient will de-escalate, at least physically. If not, follow your organization's protocol for aggressive patients. But if so...
Can we talk about this?
This is crap.
What's most upsetting to you about what you just heard?
Well, first of all, no one ever tells me anything. And second, I'm not crazy. I don't need that. I want to go home.
Is that the biggest part, not going home?
Somebody might have asked me. My mom said I wasn't going to have to go there.
Sounds to me like the biggest problem is you not being able to be included in this.
That's the way it always goes. I don't get a say about anything. And now we're just gonna lock me up? I won't be their problem anymore.
Another problem with not having a say is you don't get information about what the decisions mean or what's going to happen.
Yeah, that's nothing new either.
Can we work together about talking to your parents and doctor about how you're feeling left out about big decisions? Maybe that will help you deal with how angry you're feeling right now.
Will they let me go home then?
I don't want to get your hopes up about that. I just don't know. But I can tell you more about the psych floor and what will happen next, just in case. Okay?
Reach a common understanding about what's going to happen next, and develop a plan with the patient to resolve her anger and help her have a voice in what happens. With all of that said, it's important to acknowledge that a serious safety risk is present in patients who are physically aggressive without apparent warning, any escalation, or even an obvious triggering situation. This can occur with a lot of patients, and many times it happens with patients who have difficulty communicating or are nonverbal. In situations in which de-escalating or negotiating a positive outcome isn't going to happen, be alert when you're around this patient to protect yourself. Observe in detail things that occur before and around the time the patient strikes out, even if they seem ambiguous or insignificant. Make note of what you've observed. Confer with other team members to compare notes on what you've observed collectively. In the scenario you're about to see, the nurses are taking this approach when conferring about the patient. They're discussing a nonverbal, developmentally delayed 12-year-old female who suddenly strikes out at workers, seemingly without warning or provocation.
Hey, Brittany, I heard you had an encounter with a patient in room 12. You have a minute?
Sure, what's going on?
Well, I think if we went through it in detail, we may be able to predict her behavior better. And if we can do that, we can anticipate it or even avoid it.
At the very least, we might be able to get out of the way in time.
Yes, so let's go through it in detail, step by step. What were you doing when she lashed out?
Well, I was moving her from the wheelchair to the bed.
Okay, what happened right before that?
She was sitting at the nurse's station for a while. She likes that. Smiles a lot. Laughs sometimes.
What was going on in the room?
What do you mean?
Music, TV, visitors, anything like that?
No, I hadn't had a chance to turn the music back on yet.
Yeah, I heard she likes it on pretty much all the time.
Yes, all the time.
Well, there are at least 3 possibilities. We moved her from chair to bed. We took her away from an activity that she enjoys, and her music wasn't on. Someone else said that when she was in a room with her earlier, right before she lashed out, she noticed that she was nodding her head rapidly, but she didn't know what that was about.
You've noticed that too? I wonder if that could be something.
Well, it could mean that something's about to happen. Tell you what, let's talk again tomorrow. We can all watch for the head nodding thing and any behavior right before she lashes out and see if we find something.
Okay. Maybe I'll turn the music off for a little and see what happens. This is great. I'm feeling a lot better. Thanks for talking to me.
Sure, no worries. See you tomorrow. Bye.
Patients who are aggressive can put their care providers in a constant state of alert, which can make a day seem to go on forever. Many times it can be managed or de-escalated, and sometimes it isn't possible. Teams who observe, communicate, and collaborate can often find ways to avoid aggression or catch the outburst before it happens. Remember, you don't need to be a psychiatric professional to help a patient in this situation. You just need to know what to do. Thanks for watching.